Thank you very much, Dr. Sway. Really happy to be joining the team, and thank you for the warm welcome. So I'll be making a presentation, as Dr. Sway has said, on the standards for improving the quality of care for children and young adolescents in health facilities. So please, at any point, if I'm too fast for the translation, please do let me know. I'll share my screen now. Is it visible, please?
Yes, we can see. Yes.
Okay, great. Thank you so much. So again, thank you for everyone joining, and lovely to connect with you, even if it's on Zoom. So this is the overview of my presentation. So I think my presentation will touch on a few things. One is just giving a brief overview of the quality of care, why it matters, particularly for maternal and newborn child health. Give an overview of the framework for the WHO MSH quality of care. Then I will dive into the quality of care standards, then talk briefly about measures for monitoring quality of care for pediatric care, and then highlight a few resources at the end, which can be used in terms of thinking about pediatric quality of care from facility level up until national level. Before I hand over to my colleague, Dr. Queen Dube. So now, quality of care, and what is quality of care? I think everyone knows it, and I think we know that it's quality of care. Health services said to be of good quality when it's effective. It provides the evidence-based care to those who need them. It's safe in terms of there is no harm when you receive the care. There is no harm, and it's people-centered in the sense of that. It provides care that responds to the individual preferences. So it's not care that is designed at somewhere else in another city. It's care that is localized to the needs of the people. And we also know to realize the benefits of quality health services, it has to be timely, like to the reduced waiting time. There has to be equity in delivery of health services, such that no matter where you're from or who you are, you receive the best quality of care that's available, and that the quality of care does not vary by location or socioeconomic status or where you live, and also that it's integrated so that you are not having to receive care in different places. And also, lastly, is that you get the full benefits of the care that you receive, that you're meant to receive. And why is this important? It is important because we know that in low and middle income countries, 60% of all deaths is now due to quality of care, and only 40% is due to as a result of people not accessing care. And this comes to about 5.7 to 8.4 million deaths annually. So this is quite large. We now know that countries have made such progress that now the causes of deaths or preventable deaths are from quality of care and not access to services. For maternal and newborn health, we know that this is even crucial because we have data from the Lancet report in 2018 that shows that up to 60% of newborn deaths is caused by poor quality of care, and also up to 50% of maternal deaths. We also know that for children, when we have looked at samples and surveys about quality of care, we know that it's only about about 40% or even less than that is their adherence to guidelines. So most sick children, when they see a healthcare facility, and when they say healthcare worker in a health facility or in the community, at only 40% of the time do they receive the care according to whether it's the IMCI guidelines, whether it's the national or WHO at the global level, or even the pocketbook. So we know that this is a big problem, quality of care. We also know that in terms of health system support, that up to 40% of healthcare facilities lack running water and 20% lack adequate sanitation. And this is even worse in areas where there are protracted emergencies, in rural areas, in facilities to serve lower socioeconomic status. So we know that this is an issue. And we also know that when we look further in experience of care, we know that women, children, adolescents experience abuse. They do not receive compassionate care. And often for children and adolescents, older children and adolescents in particular, consent is usually not asked for. They often are not participate in discussions around the care that's being provided to them because they're looked at as children who have no say. So we know that these are all problems. And so for WHO, this brings us to the vision, which is that along the continuum of care, WHO's vision is that every woman, newborn child, and adolescent receives quality health service throughout the continuum of their life course and care. And this is important because without quality of care, we know that universal health coverage is not possible. And therefore, you cannot be talking about universal health coverage or even now the primary health care reform without situating quality of care in the middle of that. And this would be and so when we say the continuum of care, it's along the life course, all the way from adolescence up to maternal health and childhood, and at all levels of the health system, in the community, in the primary healthcare facilities, in the hospital. At all these levels, quality of care has to be provided at a consistent level. So the WHO framework for quality of care really takes all of this into consideration. And it's, I saw the video earlier, and yes, it's basically saying that the health, for the health system to provide quality of care for maternal, newborn, and child health, there has to be two domains of care where you focus. One is around the provision of care, which is that and this is where normally all of us focus on all the time. We think about training for healthcare workers, so making sure that evidence-based practice for routine care is provided based on guidelines and in management of routine of complicated conditions. We think also of, oh, we don't have the data. So that's things we're always thinking about. And also, how do we refer patients from one level of the health facility, one level of the health system to the higher level of health system in terms of complication? Often, all of our efforts are in this area. Rarely do we think about, particularly outside, and when we think about lower socioeconomic status, rural areas, emergency conditions, rarely do we talk about experience of care around effective communication, respect and preservation of dignity, or support for the patient. So for WHO, quality of care for maternal, newborn, child health is both provision of care and experience of care, and underpinned by two health systems function. One is around competent and motivated health, human resources for health, and also that the hospital or health facility provides care, is able to provide care because it has power, it has the appropriate facilities for women, whether it's for children in terms of child-friendly facilities or adolescent-friendly facilities, or it also has sanitation, proper sanitation and water. And that's only the way you'll be able to realize at both individual and also at a national, at a healthcare population level, improve quality of care. And this framework applies to both, initially applies to both maternal newborn healthcare, but also for the pediatric standards and also for the small and sick newborn standard that my colleague, Dr. Quinn, will also talk about us. So this is just to show how the pediatric quality of care framework, as I said, the provision of care, both the framework is the same, and the provision of care is actually the same as the standard framework. There are just some meaningful changes around effective experience of care, which is looking at effective communication and meaningful participation. And that's the discussion around how do you bring children, particularly older children and adolescents, into discussion around the care that they receive. The second is also around focusing on child rights, and then emotional and psychological support for the child and adolescent. So for pediatric standards specifically, what is the scope? As I already alluded to and I showed, it's informed by the health system building blocks. So it's when we go deep dive into each standard and what they say, you'll see that it covers every area: health financing, human resources, health information, service delivery, leadership, governance, medicines and equipment. So it's informed by the healthcare building block. For WHO and most of our care previously has been 0 to 5 years, but the standard covers 0 to 14 years. So covers 0 to 10 children and then early adolescents. So focusing on the key conditions affecting that group at a global level. What happens is that each country will also have to adapt the standards to make sure that they're also aligned with what the priorities are for their country or for their districts. It is applicable to all health facilities, so it's not just for hospital level or primary healthcare level. Any facility that is providing child health services can apply the standards to use it to set criteria or to improve quality of care. And it's also able to it's child and adolescent friendly, and also, as I said earlier, addresses both the provision and experience of care. How is it used? So the way we foresee the standards, and this can be maybe a broader discussion at the end of this, is how to use overall, not just the pediatric quality of care standard, but also the small and sick newborn standard. Is first, at a national level, the standards are supposed to be used in setting guidance. So this is where, as you're planning for health service delivery, maybe you're developing national strategies, your costing pediatric child health care strategies, like service delivery plans. What the pediatric standards can provide is that it shows you, one, how to organize care across all levels of the health system, but also to show you that what are the inputs necessary for providing care, such that you are able to be clear that what's needed. It also provides, the standards themselves also, because they're based on WHO guidelines, they also provide clearly what are what's the evidence base, and also what is the correct clinical protocol for the conditions covered there. And it also can be used and should be used. The way we have seen in many countries is that the standards are often used also at point of care quality improvement, such that you're using the standards or the quality measures underneath the standards to develop quality improvement plans to say, hey, we want to focus on pneumonia. Which area of pneumonia management are we going to focus on? What measures will we use? And how will we track performance? So that's what the standards also does. And in many countries, the standards are often included in whether it's criteria, national standards, national clinical audits, accreditation, where it's included as part of how countries assess and accredit facilities to show if those countries are rating facilities, if they're able to provide good quality or child health services. So moving into the standards themselves, we have 8 standards. We have the evidence-based practices for routine care. We have the standards around information systems, referral systems. Then we go into the standards linked to provision, experience of care, which is effective communication and meaningful participation, respect, protection, fulfillment of child rights, and emotional and psychological support. They're underpinned by empathetic human resources for health, and also child-friendly facilities. The way the standards are structured is like all the other standards. So we have the 8 standards, or one for each domain of quality of care, as I've highlighted, and those are the 8 areas I highlighted. Underneath each of those, we have 3 or more quality statements. So those statements, as for specific areas under each standard, that I'll show you in subsequent slide. So we have 8 standards. Underneath that, we have 40 quality statements that cuts across diseases, health information system, organization of health information system. And underneath the statements, we have what we call the measures, which is input, output, and outcome measures. So what is needed to be able to meet each statement? So what are the inputs needed? How can you measure if you're meeting the statement from the input level? How can you measure from a process level, which is what's happening, and the output level, and what are the outcome measures? These measures are actually important because these are the measures where, particularly at facility level, when you're setting up quality improvement projects, when you're trying to improve quality of care, is these measures that you use to set your quality improvement areas and agenda, because these are what is their measures, their objectives. They help to be able to set specific goals, measurable goals, and also help you with in terms of designing how you're going to track improvement over time. So this is what at most levels, healthcare workers at the facility level will be using to be able to meet the statement and obviously at the end also the standard. So I've gone through this already, so not to take time. I won't go through this. This is just listing, highlighting more clearly each of the standards. So I said this is for provision of care, which is every child receives evidence-based care and management of illness according to WHO guidelines. The second is around that the health information system is robust enough to not only collect data, but you can use it for analysis, and data is actually being used. And that the third standard is that every child condition that cannot be managed is appropriately referred to the next level of health facility. For the experience of care, we have, it is that communication with children and their families is effective, with adolescents participating, and healthcare workers respond to their needs and preference. That's focus on child rights. This is an area where we have done a lot of work, but when we go to countries and at facility level, less work is being done here. So I'll highlight that during the presentation. And then that's all children and their families are provided with the necessary education, emotional, and psychological support that is sensitive to their needs. And I already highlighted this, the areas around appropriate with trained healthcare workers, and also a child-friendly facility, which also has adequate water, sanitation, energy, and supplies and medicines. So what I'm going to do now in the next couple of slides will be just to go through each of these standards with their statements. Because there are about 40 statements, I'm not going to describe in detail each of the statements, but it's just a way of highlighting to you what each of these standards covers, so that it can inform the discussions we can have at the end. I think it's also important to realize that for each of these statements, countries will need to prioritize if these statements are relevant for their setting, if there are other statements that are necessary but are not in this global level of statement, which therefore they will add to their situation. So the first standard, which is around every child receiving evidence-based care and guideline, you can see we have 15 quality statements. And it starts from the first, which is looking at triage. That's as a child arrives in the facility, that they receive necessary and required emergency and priority emergency assessment. They're tried appropriately and receive the correct treatment to resuscitate a very ill child. The second is around management of sick infants and newborns. Then the rest are basically, they're linked to, if you follow the IMCI guideline. The third statement is on cough and difficulty in breathing. The fourth is on diarrhea. The fifth is on fever. The sixth is on growth, appropriate growth assessment for growth monitoring, breastfeeding, and counseling, and on and on. So it includes HIV, tuberculosis, malnutrition, vaccination, chronic condition. Importantly, statement 11 also looks at, which often we don't do, evidence for maltreatment or violence, and then on surgery and also follow-up of care. So these are the conditions that most children who are seen at facilities have. However, as you know, that you can see that depending on where you are, depending on the locality, there are some other areas, some other conditions which are not here, which might be relevant for your setting. For example, dengue fever is not here. Some hemorrhagic fever, which are also endemic in some places, are not here. So countries will have to look at this statement and adapt which is all of these are usually relevant in all settings, but also see that which other common disease or illness do we have is endemic in our locality, which needs to be added here. So it's not just adapting the WHO, the standards and just taking only these 15 statements. Countries also have to look at which additional disease area or condition should be included here. For the standards on health information system, there are 3 statements, and these statements link to one is that in each health facility, the correct architecture for health information system is present. So the medical records are up to date based on the national standards, and it's also available. And then the second is that there is a function and process to review and analyze and collect data as part of routine activities. And the last is that not only do you do those first 2 statements, but you also begin to look at how are you using the data. So data is not just collected and kept, but that healthcare workers use the data, but also not only healthcare workers, the data flows to a higher level, to the district, to the province, and also to the Ministry of Health. And data is being used constantly to understand what's the quality of care that's being provided. So this is on referral, and just basically saying the statements are linked to the, how to quantify referral service. So one is appropriate referral care. So you just don't refer that at each facility that they're able to provide the appropriate pre-referral care. There's a referral plan in place, and also when children are referred, there's appropriate exchange of information back, upwards and downwards. So this is looking at the whole referral process. Now, around communication, these standards, the key thing in these statements, which there are 4 statements, which looks at the fact that they go from that all children. So often we do handle children as not being important, and often even when there is dialogue between the healthcare worker and the caregiver, it's usually limited to those 2 people, the mother, the father, the aunts. Usually children, particularly older children, just don't participate in communications around their health. So this statement is around one. The first statement is that children do have information about their illness, and so they understand what it is and what treatment they're receiving. And then that they're often, particularly in children with chronic conditions, that there is coordinated care between the healthcare workers, the social worker, and other professionals who are involved in care, and such that the child is protected. And then children are able to give consent, and whether it's to accept care or actually to refuse care, particularly older children and adolescents, or to decide what type of care they want. And then that they also receive appropriate counseling about their health condition and their current illness. So this is more moving from provision of care to also saying, how do we involve children in their care? So the next is around how around children's rights and how to minimize harm. And often in health facilities, most children usually will usually say, oh, we protect children. So children often receive care, but often we see, particularly in areas of conflict, where people of some children might be discriminated against because of who they are or whether it's a religion or ethnic group. So is that all children have the same access of right to care, no matter who they are. And then in each facility, you have the Child's Rights Charter. So understanding what are the rights of the children, and that children also and their caregivers are treated with respect and dignity, and there is no form of physical, mental abuse in the facility. Healthcare workers are not insulting or abusing parents or children. And that also when children are admitted in health facility, they do have access to nutrition, because often when children are admitted in facilities, parents and caregivers have to go out to source for their food. So this is also saying that health facilities, where possible, should try and provide the adequate nutrition to children. And the last standard on experience of care is around looking at ensuring that children and family are together during care, and that they receive emotional support, and they're not, when children have whether it's chronic conditions or are receiving hospice care, they are not in inappropriate pain. They receive they receive appropriate care that prevents them from being in pain. The last two standards are on the health systems, and one, as I said, one is the first is around adequate trained healthcare providers who are trained in child health, who have received up-to-date training on evidence-based, on the new evidences for management of childhood condition. They have access to job aids, and they have the right skills to be able to manage children. So they have also received appropriate treatment for children. And then they have an overall managerial support at the facility level that also helps to ensure that they're supported. Healthcare workers are also supported by the facility and also by the district in providing their health services. And then the last standard is around a child-friendly health facility, and looking at one, a well-maintained safe space, access to water and sanitation, a child-friendly space. Often, I was just in Vietnam last week, and what we found that in many health facilities, children are just, there are no dedicated emergency wards for children. So children are just seen in the same wards as adults. And often what that means is that when there's an emergency, it's unclear where the child appropriate devices or tools are, the appropriate size cannulas, things like appropriate size cannulas or masks are often not found because there is no dedicated space. It's not organized to provide services to children. So this is, and then often we have that even sometimes where there is no stock out, medications might only be available in ampoules that are for adults. So it's also ensuring that all in facilities there's essential drugs and commodities specific for children, sorry. So that's all on the standards. I now will go through a few slides just because I want to emphasize around not only the standards, but also measurements and monitoring and how that works. So the pediatric quality of care standards are basically, the pediatric quality of care indicators are basically measures to be able to, indicators that WHO has developed for being able to track, to help countries to track the quality of care for child and pediatric services at country level. And we have 25 in total. And it's important to understand how these are organized. So we have three, when thinking about measurements and quality improvement, it's important to think about three levels of measurement. What I'm going to emphasize in the next two slides are around the global core indicators, which is just a very small prioritized small set of input, process, and outcome indicators, which basically countries will take and apply as relevant for them. So countries do not need to apply, or countries or districts do not need to adapt or include all 25 in the health information system if they're not relevant for their setting. And also countries can review and adapt and add indicators that might be missing from this list as appropriate. This is what we call the global core indicators and what I'll just focus on. However, in addition to that, we have the quality improvement indicators, and this is the measures which I talked about earlier. And these are already available in the standards, and these are basically focused for point of care and maybe at district level. All these measures are, the measures and quality improvement indicators do not necessarily need to be tracked at the higher level of the health system, but these are the measures which healthcare workers and district in their day-to-day work use in terms of tracking quality of care and tracking quality of care projects, sorry. And last is just milestones which countries will have to decide and think about. How do we know that quality of care, how do we know we're driving towards quality of care, assessing what milestones are happening at different levels for quality of care. So these are just more around managerial milestones. They're not clinical indicators. And we have, I'll highlight one guide where you can track, you have access to those milestones. And so this is around thinking broadly around how do you implement a quality of care program. So for the list we have, so as I said, the list cuts across from impact to outcome to process to input. I'm broadly looking at on child mortality rate, case fatality rate, then a lot of process indicators around is IMCI probably properly institutionalized for assessing the sick children? How is PSBI treated at outpatient level? How is kangaroo mother care provided? How is so things like that, treatment of pneumonia, management of malnutrition or malaria. Then also some work on HIV testing. There's some input which is looking at experience of care, which is at opportunity for vaccination, looking at patients and knowledge understanding of their condition, decision-making, counseling, child rights. So it cuts across both provision and experience of care, but also goes into the health system aspect, which includes, have you looked at the data? Is there an ongoing process to review the data? What are the appropriate quality of care indicators for pediatrics? And also at health system level, is there support for healthcare workers in terms of mentorship, training, what's happening? And also, so all countries will need to review this list. There are 25 of them, and countries will need to make decisions about what goes into their own pediatric national pediatric quality of care indicators list. And just a quick process which we're supporting countries, and it would be useful to hear feedback about how this is happening in Myanmar. So one is that, as I said, which is what I'm doing now is to share these indicators and their metadata. So basically, how do you develop these indicators? What goes into defining the indicators, and discuss this. And now look at the health information system to see which of these indicators can be collected, because that also informs if the indicator can be included in the health information system. But also that process also includes what are the other indicators that are not part of this list, but should be included into the list. And then agreeing on a process where over time to include all of these indicators, not only in the health and the DHIS, but also how these are reflected in the medical records that are being used in health facility level, so that you're able to track these indicators over time. So this is something that it's not a one-day process, it's a process that goes over time. But what is important is that as we go through health sector reforms, whether it's through the Global Fund investments or World Bank investments, where they're looking at health information systems, for MNCH, we're also thinking about what opportunities exist to also bring in quality of care indicators. So this is my final slide, and I just want to highlight a few tools and approaches that can be relevant for quality of care. We have the implementation guide, which is a managerial guide to say that to outline what are the steps at national, district, and facility level for implementing the quality of care, maternal, newborn, and child health quality of care program. This is something that I would say that perhaps maybe in another webinar, it would be good to have a dedicated webinar on this and brings together all of the discussions that are happening. The second is around the standards, which I've talked about. The next is also the pediatric death audits, so similar to MDSR, but for children, similar to maternal death surveillance and response, but for children. So the pediatric death audit tool, which we have also, then we have the pocket book, which we're currently updating, but it's the reference guide for hospital care. Then we have the IMCI chat booklet, which is the reference guide for clinical management of children in primary healthcare facilities. Then we have the ETATs, which is around how to provide quality care for children presenting in emergency, critically ill children. And then we have the point of care quality improvement book, which is basically a training manual for healthcare workers to, in terms of how to develop quality improvement projects and how to track their performance. So it's a book that's how to, but for healthcare workers at facility level. So that's my final slide. And thank you so much. I'm really grateful of this opportunity of speaking with you. Thank you. Over to you, Dr. Sue.
Thank you, Doctor. Thank you, Doctor, for your insightful presentation. Dear attendees, before we proceed, let's enjoy a video clip that we prepare for you on standard on the quality of care for the children and young adolescents. Please enjoy.
ကမ္ဘာ့ကျန်းမာရေးအဖွဲ့ WHO အနေနဲ့ကျန်းမာရေးဌာနတွေမှာကလေးငယ်နဲ့ဆယ်ကျော်သက်အစောပိုင်းအရွယ်များအတွက်အရေးသွေးပြေးဝတဲ့ကျန်းမာရေးဆောင်ရှောက်မှုအရေးသွေးမြင့်တင်ရေးမူပေါင်းတစ်ခုကိုရေးဆွဲပြဋ္ဌာန်းထားပါတယ်။အဲ့ဒီမူပေါင်းထဲမှာဆိုရင်စံနှုန်း standard ၈ခုပါဝင်ပြီးတော့၎င်းစံနှုန်းတွေကိုအဓိကအုပ်စု၃စုအနေနဲ့ခွဲခြမ်းစိတ်ဖြာကြည့်လို့ရပါတယ်။အဲ့ဒီအဓိကအုပ်စုကြီး၃စုကတော့ကျန်းမာရေးဆောင်ရှောက်မှုပေးခြင်း provision of care ကုသမှုခံယူနေစဉ်တွေ့ကြုံခံစားမှု experience of care နဲ့ရရှိနိုင်သောကျန်းမာရေးစနစ်ရဲ့ရင်းမြစ်များ health system resources တို့ပဲဖြစ်ပါတယ်။ဆက်လက်ပြီးတော့စံနှုန်းတစ်ခုချင်းစီအကြောင်းကိုပြောပြခြင်းပါတယ်။စံနှုန်းတစ်ကတော့အထောက်အထားအခြေပြုကျန်းမာရေးဆောင်ရှောက်မှုပဲဖြစ်ပါတယ်။ကလေးငယ်တိုင်းဟာကမ္ဘာ့ကျန်းမာရေးအဖွဲ့ WHO ရဲ့လမ်းညွှန်ချက်တွေနဲ့အညီအထောက်အထားသက်သေသာဓကတွေကိုအခြေခံထားတဲ့ကျန်းမာရေးဆောင်ရှောက်မှုနဲ့ပြုစုကုသမှုတွေကိုရရှိကြရပါမယ်။လိုအပ်သလိုအရေးယူဆောင်ရွက်နိုင်တဲ့သတင်းအချက်အလက်စုဆောင်းဖြန့်ဝေမှုစနစ်တွေကိုတော့စံနှုန်းနှစ်ဖြစ်သတ်မှတ်ထားပါတယ်။ကလေးငယ်များအတွက်ကျန်းမာရေးဆောင်ရှောက်မှုပုံမတိုးတက်ကောင်းမွန်စေရေးအတွက်လိုအပ်တဲ့အရာတွေကိုစောစီးစွာနဲ့မှန်မှန်ကန်ကန်ဆောင်ရွက်နိုင်ဖို့လိုအပ်ပါတယ်။အဲ့ဒီလိုဆောင်ရွက်နိုင်စေဖို့ကျန်းမာရေးသတင်းအချက်အလက်တွေကိုစနစ်တကျစုဆောင်းခြင်း၊သရုပ်ခွဲခြင်းနဲ့ထိရောက်စွာဖြန့်ဝေအသုံးပြုခြင်းတို့ကိုဆောင်ရွက်ရပါမယ်။စံနှုန်းသုံးကတော့ညှိနှိုင်းမှုစနစ်နဲ့ပတ်သက်ပြီးပဲဖြစ်ပါတယ်။လက်ရှိရောက်နေတဲ့ကျန်းမာရေးဌာနမှာရနိုင်တဲ့ရင်းမြစ်တွေဟာကလေးရဲ့ကျန်းမာရေးပြဿနာအတွက်တကယ်လိုအပ်တဲ့ကုသမှုတွေကိုထိရောက်စွာပေးဖို့မလုံလောက်ဘူးမဖြစ်နိုင်ဘူးဆိုရင်ကလေးကိုစဉ်ဆက်မပြတ်ထိရောက်တဲ့ကျန်းမာရေးစောင့်ရှောက်မှုတွေရရှိစေဖို့တင့်တော်တဲ့ကျန်းမာရေးဌာနကိုအချိန်ကိုက်လွှဲပြောင်းမှုဖို့ပေးရပါမယ်။စံနှုန်းလေးကတော့ဆက်သွယ်ပြောဆိုခြင်းတွေနဲ့သက်ဆိုင်ပါတယ်။ကလေးငယ်များနဲ့မိသားစုဝင်တွေကိုပြုစုကုသမှုပေးရမှာ၎င်းတို့ကိုယ်တိုင်ထဲထဲဝင်ဝင်ပါဝင်စေခြင်းဟာ၎င်းတို့နဲ့ကျန်းမာရေးဝန်ထမ်းများအကြားဆက်သွယ်ဆောင်ရွက်ခြင်းကိုထိရောက်စေနိုင်တယ်လို့သူတို့ရဲ့လိုအပ်ချက်နဲ့သူတို့ဖြစ်စေခြင်းတဲ့အတိုင်းတုံ့ပြန်ဆောင်ရွက်မှုတွေကိုပေးနိုင်မှာပဲဖြစ်ပါတယ်။ကလေးငယ်များရဲ့အခွင့်အရေးများနဲ့ပတ်သက်ရင်တော့စံနှုန်းကမှတွေ့ရှိနိုင်ပါတယ်။ကျန်းမာရေးဆောင်ရှောက်မှုပေးရမှာဘယ်လိုခွဲခြားဆက်ဆံမှုမျိုးမှမရှိစေပဲကလေးငယ်များရဲ့အခွင့်အရေးအလုံးကိုအချိန်တိုင်းလေးစားရပါမယ်။အကာအကွယ်ပေးရပါမယ်။လိုအပ်တယ်လို့ဖြည့်ဆည်းပေးကြရပါမယ်။စံနှုန်း6ကတော့စိတ်ပိုင်းဆိုင်ရာခံစားမှုတွေကိုပံ့ပိုးပေးဖို့ပဲဖြစ်ပါတယ်။ကလေးငယ်များနဲ့မိသားစုတွေကိုအသိပညာစိတ်ပိုင်းဆိုင်ရာနဲ့ခံစားမှုဆိုင်ရာတွေမှာကူညီပံ့ပိုးပေးရပါမယ်။အဲ့လိုဆောင်ရွက်ခြင်းဟာ၎င်းတို့ရဲ့လိုအပ်ချက်တွေကိုပုံမသိရှိစေနိုင်ပြီး၎င်းတို့ရဲ့ကိုယ်စွမ်းကိုယ်စားများကိုလည်းပုံမမြင့်တင်ပေးရရောက်ပါတယ်။ကျန်းမာရေးလုပ်သားရင်းမြစ်နဲ့သက်ဆိုင်တာကတော့စံနှုန်း9ပဲဖြစ်ပါတယ်။ကလေးငယ်များကိုပြုစုဆောင်ရှောက်ဖို့နဲ့ကလေးဘဝမှာအဖြစ်များတဲ့ကျန်းမာရေးပြဿနာတွေကိုကုသမှုပေးနိုင်ဖို့အတွက်အရေးချင်းပြည့်ဝပြီးတက်ကြွတဲ့ကိုချင်းစာနာတတ်တဲ့ကျန်းမာရေးဝန်ထမ်းတွေကိုအမြဲတမ်းခန့်အပ်ထားရှိရပါမယ်။နောက်ဆုံးစံနှုန်း8ကတော့ဝန်းကျင်ကောင်းတွေဖန်တီးပေးဖို့ပါ။ကျန်းမာရေးဌာနတွေမှာကလေးငယ်နဲ့ဆယ်ကျော်သက်များကိုကျန်းမာရေးဆောင်ရှောက်မှုပေးတဲ့အခါ၎င်းတို့နဲ့စီလျော်တဲ့ဝန်းကျင်တစ်ခုကိုဖန်တီးပေးဖို့လိုပါတယ်။ရေကောင်းရေသန့်လုံလောက်စွာရရှိခြင်းဆေးရုံဆေးကမ်းပတ်ဝန်းကျင်ကိုတန့်ရှင်းအောင်ထားခြင်းအညစ်အကြေးနဲ့အမိုက်များကိုစနစ်တကျဆွန့်ပစ်ခြင်းရက်စက်မီရရှိစေခြင်းကလေးငယ်များကိုပြုစုစောင့်ရှောက်ရန်နဲ့ကလေးဘဝတွင်အဖြစ်များတဲ့ကျန်းမာရေးပြဿနာများကိုကုသမှုပေးရန်ဆေးနှင့်ဆေးပစ္စည်းကိရိယာများရရှိအောင်ဆောင်ရွက်ထားရှိခြင်းစသည်တို့ဆောင်ရွက်ပေးရပါမယ်။ဆယ်ကျော်သက်နဲ့ကလေးငယ်တွေရဲ့အခြေခံခွင့်ရတစ်ခုဖြစ်တဲ့အရေးသွေးမြင့်ကျန်းမာရေးဆောင်ရှောက်မှုတွေကိုရရှိစေရန်ရည်ရွယ်ပြီးဒီစံနှုန်းတွေစံသတ်မှတ်ချက်တွေကိုသတ်မှတ်ဖော်ဆောင်ရခြင်းပဲဖြစ်ပါတယ်။ဒါကြောင့်မို့ WHO အနေနဲ့ ကလေးငယ်နဲ့ဆယ်ကျော်သက်များအတွက်ကျန်းမာရေးဆောင်ရှောက်မှုပေးနေတဲ့ကျန်းမာရေးဌာနတိုင်းမှာဒီစံနှုန်းတွေကိုသတ်မှတ်ပြီးလိုက်နာဖော်ဆောင်ကြဖို့အလေးအနက်တိုက်တွန်းလိုက်ပါတယ်။
Thank you for watching. So we hope it enhances your understanding of the quality standards. So dear honorable attendees, now let's move on to our next speakers, Dr. Quinn Jude, who will be sharing the standard for improving quality of care for small and sick newborn in her facility. So Dr. Quinn is a medical officer for newborn health, maternal, newborn child, and adolescent health and aging at WHO headquarters. She's leading the works on newborn program implementation, policy, and standard at WHO headquarters. She's also currently the co-chair of the ENET and EPMM country implementation group. She has led several research studies on the small and sick newborn, point of care diagnostics, HIV, malaria, diarrhea, and emergency pediatric care. She's also a part of barrier technical advisory panels for neonatal research trials across the globe. Prior to joining WHO, she was the chief of health service in the Ministry of Health of Malawi. She is a pediatrician and clinical epidemiologist holding doctorate degree from the University of Liverpool. So without further delay, I would like to cordially invite Dr. Quinn to the floor. So dear Doctor, the floor is yours.
Thank you very much, and thanks a lot for inviting myself and Nuhu to share on the quality of care standards for both pediatrics and the small and sick newborn. Actually, the newborn is part and parcel of pediatrics. You start by being a newborn before you hit in what we call the proper pediatric age group. Can you see my screen? Can you see my screen?
Yes, we can see.
Thank you. Okay. So Nuhu touched on some of these things, so I will run very fast on the initial couple of slides and really spend a bit more time on small and sick newborn care. But just to emphasize that, this has an impact on human life. So 295,000 mothers and 2.5 million newborns die annually. If you remember, Nuhu did talk about 60% of newborn deaths being attributed to poor quality care. So in terms of numbers, you're really talking about 1.5 million newborns dying annually due to poor quality care. We have countries that have a population of 1.7 million, 1.5 million. So, when you think about it, it's actually something that we shouldn't be living with, but that's what it is. But the majority of these deaths actually for the newborn are occurring around the time of birth. And let's not forget an equally important area, and that's stillbirths. And so we're having about more than 2 million stillbirths every year. So if you combine that to the newborns, we have about at least 4.5 million. And then when you look at the magnitude of newborns that have that require access to quality services, we're talking about 30 million newborns across the globe. You could put in figures for Myanmar in terms of your small and sick newborn population. But when you talk about quality of care, it's not just a problem of the low and middle income setting. When you look at the high income setting, about 10% of patients are actually harmed whilst receiving care. And Nuhu did talk about the fact that 40% of our health facilities lack running water, which is a very, very, very basic need. And when you look at women experience, this is based on surveys and research, A lot of women experience abuse, lack of respectful, compassionate care, and exclusion from care decisions making during childbirth, and also in relation to infant care, specifically small and sick newborn care. So it's not uncommon to find that mothers are not actually allowed in the newborn care unit in some facilities. And in terms of decisions that are made, the mothers are just outside the decision-making process. And when you look at the newborns are subjected to harmful procedures, lack of respect for care, neglect, and actually separation from their families. We need to remember that when we're having a discussion around quality of care, we need to remember that it's about saving lives. And we know that if we did the right things from pregnancy, around the time of birth, and then the postnatal care of the mothers and the babies, but also care of the small and sick newborn in the hospitals, we could be able to save many lives. And I hope that we're all aware of the INAP and EPMM joint targets that 90% of our women should have at least the 8 antenatal care, quality antenatal care visits. 90% of our women should have deliveries attended by a skilled birth attendant. 80% of our mothers and newborns should have postnatal care, and then 80% of our districts should have at least one level 2 unit. So I'm going to come back to these figures later on. Let me not overemphasize the fact that we do have a huge quality gap, and this is costing many lives. Now, sometimes, at a country level, we run so fast in terms of coverage. So we set up units, we open other hospitals, we set up community systems, and many times the quality piece is lagging behind. And if we just focus on coverage and not focus on quality, we will never get impact. You need to have the right combination of coverage plus quality for us to be able to see impact. And it's not surprising that we've seen, when you look at the global data, we've seen an increase in the number of women delivering in the health facilities, or the deliveries being attended by a skilled birth attendant. But when you look at maternal mortality, we've plateaued. So no progress at all from 2015. Yet a lot more women are coming for antenatal care. A lot more women are coming to deliver in the facilities. Why? Because we haven't addressed the quality gap. So really excited that we're talking about the quality issues today. So if you forget anything about what I'm going to talk about, remember, coverage without quality, zero impact. We need both coverage and quality to get the impact that we need. Nuhu talked about this slide, about the WHO vision, and he also eloquently went through this particular slide, and he also went through this slide and this slide. So I'm going to jump a couple of slides. Now, let me come down to the standards of care for the small and sick newborn. Now, if you remember the history, if you've been following the quality of care standards for both since time immemorial, so we did the pediatrics, we did the maternal and newborn, and then the small and sick newborn was it came at towards the very end. Within the maternal and newborn standards, we were covering just the first week of life, and so we felt that the neonatal period is actually the first 28 days of life, and we needed to actually cover that gap. So the standards of care for the small and sick newborn were really aimed to define and standardize the mainstream inpatient care of small and sick newborns, building on the Essential Newborn Care Platform. So the Essential Newborn Care Platform was well elaborated in the maternal newborn care standards. and also to guide countries in caring for this vulnerable population and support quality of care of newborns in the context of the universal health coverage. It's very, very consistent in terms of approach and framing with the WHO quality of care framework and quality, equity, and dignity initiative. So this is specifically looking at this important population of small and sick newborn. And remember, we have an INAP target where every district should have at least one level 2 unit. And I'll come back to what that level 2 unit is supposed to look like. So I did mention that the existing standards lacked specificity for small and sick newborns. And I mentioned that the maternal newborn standards were targeting the time of birth and the first week of life and very much looking at essential newborn care. And then the WHO pediatric and young adolescent standards were actually lacking evidence-based interventions for the small and sick newborn. Now, coming back to the conceptual framework and scope of the standards, and Nuhu did talk to some of these, but let me just emphasize that these are also applicable to all health facilities offering maternity and newborn care services. It does cover both the essential care and also the care for the small and sick newborn, with the newborn and the family as a centerpiece. And within these standards, there is specificity for the priority thematic and thematic areas, and we have about 8 standard domains. So the 8 standard domains cover both the process and the process in terms of the provision of care and the experience of care. And again, Nuhu did talk into this slide, but really it's for us to be able to assist countries in terms of organization and planning for the introduction of small and sick newborn care in the facilities. Actually, only 40% of countries within the low and middle income settings have started to push the level 2 agenda. So really, really important that countries take on board the guidance on how they can organize and also introduce quality small and sick newborn care within our countries. So 8 standards in total, and each standard has 3 or more quality statements. And then you also have several input and output, but also outcome measures per quality statement. So you start with a standard, you have then quality statements. Under each quality statement, you have your input, output measures. So just to give you an example, and apologies, this is a very busy slide. When you look at standard number 1, say, for example, where we're talking about every small and sick newborn receives evidence-based care and management of illness according to the WHO guidelines, then you have under standard 1, then you have quality statements and really all based on evidence. So under the quality statements, you have care for all newborns. This is your essential newborn care. And then part B is where you have care for small and sick newborns. Because sometimes we focus very much on the more complicated stuff, and then we forget the essential newborn care. You can put a baby on CPAP, but if that baby is cold, you will not save their lives. If the baby is cold, you increase their risk of dying. So that's why we're starting on the provision of care under the quality statements. We're starting with that which is supposed to be a foundation, your backbone, care for all newborns. And then under care for small and sick newborns, you do have several care, statements on the various conditions that we deal with in as far as a small and sick newborn is concerned. So really interesting. So for example, on essential newborn care, one simple quality statement: all newborns receive care with standard precautions to prevent healthcare associated infections, including implementing additional measures required during outbreaks and pandemic situations. So this one really is highlighting, the importance of infection prevention and what countries or facilities are supposed to be doing to really make sure that newborns do not end up with a hospital-acquired infection. Now, on just giving you an example again, still under quality standard number 1, yeah? So when you look at quality statement B, where we're talking about care for small and sick newborns, for this one, say, for example, you pick up 1.28, yeah? So it's talking about all newborns are routinely monitored for jaundice. Bilirubin is measured in those at risk and treatment initiated in those with hyperbilirubinemia according to WHO guidelines. Now, when you look at this quality statement, it then pushes you at a country level to ask yourselves, do we have a system that enables us to routinely monitor for jaundice? If not, what is it that we need to do? So you look at it as a package using the health system building blocks that Nuhu talked about. So this is, again, a very, very, very busy slide, but it's just highlighting the inputs that you will need for those quality statements under B. So issues around guidelines, protocols, standard operating procedures, and so on and so forth. So the way these have been framed is really, really excellent in a way that you can use them at both a national level, subnational level, but also at a facility level to set up a system that is robust enough to move the small and sick newborn agenda. And then again, within the same standard 1, there is also a piece around data, clinical monitoring and supporting care. What is it that we need to be doing? Sometimes these babies, say, for example, you have your CPAP or you have a phototherapy machine. So a baby is put on phototherapy, but there's no monitoring. So there's no quality. So the gadget is there, your nurse is there. You've put the baby under the right treatment, but because there's no monitoring, you might not get the impact that you were looking for. So it's really, really important that we look at these standards with a holistic and comprehensive approach, and not pick and choose which ones we want to use. You need everything to really get the impact that you need. I talked a little bit about the levels of care, and we'll be able to share the INAP document that talks into the levels of care. But essentially, we're really talking about 3 major levels of care. So the primary is where you're doing your immediate and essential newborn care. So issues around delayed cord clamping, drying of the baby skin to skin, neonatal resuscitation, early initiation of breastfeeding. But then when you get into your secondary level, this is where we now start to talk about the special newborn care units. Yeah, so where you have these unstable babies, small and sick newborn babies, babies with infection, babies who are preterm, babies who are asphyxiated. So you are then talking about special care for these babies who are jaundiced. So you're getting a little bit higher level care. And then there's a transition phase where within that secondary level, you've now added CPAP. And the tertiary level is really ICU, where you're ventilating babies and you're doing a lot more complicated stuff. So the INAP target is really on the secondary and transition, that 80% of our districts should have quality level 2 care services. Let me emphasize on the quality standard on experience of care, because this is poorly done for the newborn. And many of us forget that the newborn has identity, has feelings, has emotions. And now we know with evidence that some of the harmful practices that we've actually subjected these newborns to have had an impact on their neurodevelopment. So it's very, very, very important that we pay really close attention to the experience of care for the newborn. Issues around pain, issues around allowing the carers, the mothers, to be there with their newborns, issues around zero separation. So this is well covered under this standard on experience of care. And then there's a whole standard number 5 that talks about, again, really talking about the experience of care, tackling respect, protection, and fulfillment of newborn rights and preservation of dignity. There's also a standard on emotional, psychological, and developmental support. This is very, very, very poorly done. So our sick newborns are subjected to very noisy environments. There is no developmental care at all. There isn't even, once the newborns, if you do have a small and sick newborn unit, once they've been discharged, it's like, bye-bye. I will see you when you have a problem. So no properly set up follow-up systems. So this standard really talks about how we address those very, 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 very critical environments. And how do you exactly do proper developmental support in a very overcrowded small and sick newborn care unit? One critical evidence-based intervention is kangaroo mother care. And it's unfortunate that coverage for quality kangaroo mother care is still lacking behind. But we know it has impact on mortality. We know it has impact on good neurodevelopmental outcomes in these babies. So we do have also a whole host of input, process, or output and outcome measures for the quality statements that really are looking into the experience of care. Now, let me run through this also very, very, very important standard that looks at the resources that are available. The resources that are available looks around capacity building, skills for those that are looking after the small and sick newborn. Sometimes we get nurses, just because we have huge gaps, we get nurses that have no idea of what it means to look after a small and sick newborn. And sometimes, because we've done that, we end up in a situation where we can't provide the quality care. So it's not just about having the numbers in the units, it's also making sure that they have the right skills. They have the right supervision. We have a way of continuous professional development for these cadres that are working in the unit. And one big thing is rotation. So in a lot of the LMICs, there is a system around rotating staff. Every 6 months, you rotate. Now, in these specialized units, small and sick newborn, that has a huge impact on mortality outcomes. So data has been able to show us that the first 3 months when you have rotated people, your mortality, inpatient mortality rates, they go really up. And then it's on the 4th month that you are kind of going back to the baseline. And before you know it, you have done another rotation. So I don't know the situation in Myanmar, but this is one big area that has an impact on quality of care. Let me finish with this one that talks about essential physical resources. So a lot of our hospitals, when we were building them, we didn't think about the small and sick newborn. So what we've done is to improvise one little room where we call it the KMC unit or the small and sick newborn care unit. Now, infrastructure is such a big piece in as far as quality of care is concerned. You cannot do proper infection prevention in an overcrowded little tiny room. You see the picture at the bottom. Unfortunately, even in 2023, we have facilities that look like this. So it's important that you, at a country level, subnational, national, subnational level, you really look at floor plans for small and sick newborn care units that will then allow you to provide that quality care piece for the small and sick newborn. Let me finish with these few slides. And Nuhu did talk a little bit. He talked quite a lot on moving from evidence to implementation and impact. And it's very, very important that this quality of care agenda should be driven from the ground. It's good to push it from the national level, but if you really want to see sustainability, institutionalization, it has to start from the ground. The people from the community level, they must own it. Otherwise, you can develop your policies, you can establish units, but if there's no ownership from the ground, this doesn't move at all. So somewhere, somehow, you need both the push and the pull effect. What have we learned from a couple of countries that have introduced level 2 care with quality at the back of their minds? It takes a whole system. It takes a whole system. Yeah, so you need the health workforce piece to tick. You need your referral systems to tick. You need the financing part to tick. You need the data systems to tick. You need your health workforce, service delivery. So all those pieces, they must all be working. Government leadership and long-term commitment is a prerequisite for success. Government must own this. And then you cannot do quality of care if there's no investment. So continued investment for quality of care, together with bringing in other partners, is really, really key. So in a lot of our countries, challenges are around funding and also coordination amongst stakeholders. Now, I'll just highlight a few things that we're learning on the small and sick newborn agenda, and that's strengthening of subnational capacities. So you can do a lot at a national level, and yes, that will make you gain a few miles, but implementation actually happens at a subnational level. So really strengthening the subnational level capacities is very, 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 very critical. I talked about data systems. And let me finish with this slide. How can we get faster progress together? People say failing to plan is planning to fail. So we need an integrated plan that is holistic, but really aimed at moving the small and sick newborn agenda. Nuhu will say moving the pediatric agenda as well. Have targets in mind. Where do you want to get to by 2030? Look at how you're going to invest. Where is the money coming from? And how do we track the budget? Implement, 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 with a focus on service delivery and results, as well as inputs like drugs and devices. So for small and sick newborn care, you cannot do it without drugs and devices. And finally, look at impact. If you cannot measure it, then you cannot improve it. So impact, it's very important that we also look at how we're measuring outcome and coverage with quality and using local data to drive the sustainable change. If we can only have a robust integrated plan, have the right investment, start to implement and measure what we're implementing, improving as we go along, surely we will have sustainable change. Thank you. Let me stop there.